I do a task. So more than 15% is the latarjet, less than 10% I would definitely do the Bangalore. The contraindication would be massive bone loss and subscapularis tears. So before I start off with the latarjet, the question is, will I do a remplissage with remplissage and the latarjet? So my concept is that when we look at, we have quite a bit failure rates with the Bangalore. When we look at the outcomes of our latarjet, not even the arthroscopic latarjet, the latarjet outcomes, 3% is the frank instability, frank dislocations are 3%, and 13% is the relative instability. That means it slips, but it's not dislocating properly. What are the possible reasons? Let's look at this particular picture, which shows that even if you do a latarjet, if it's a massive hill sash, or if the hill sash, which is a mid-lice hill sash, in those kind of cases, it can still slip. So now, that's why I find arthroscopic latarjet a useful tool, because I can do a remplissage and then I can go in with the arthroscopic latarjet. So I always do this, and this is what I was saying. My logic behind doing the arthroscopic latarjet with the remplissage is this. And I always do the CT is done and the tracking is done, seeing if it is on track, off track. So we did this particular study where we found that even if we do latarjet, it's still off tracks, at least in 15% patients. So we did all our cases. We found that if it is off track, on track, that is off track, on track, preoperatively, off track, on track, post-operatively with the coracoid graft. So we found that still it is off tracking in 15%. So that correlates with the data we have. Look at the data. Data talks about 13% is instability. So doesn't that correlate with something which is happening inside, something which we're not doing right? So that is why we do our remplissage in our cases. So this is how the CT and the tracking is done. So coming to the arthroscopic latarjet, so the regular latarjet is good. We can do it. It has been there so many years. It gives us excellent results. Why I do the arthroscopic latarjet is because one, it was challenging. Second is we can always do an arthroscopy, visualize what is happening inside. We can take care of any cartilage defects, any slab tears, anything, whatever is happening, we can have a look inside. That is and definitely I can do the remplissage. That's why I do the arthroscopic latarjet. So rates of recurrence I've already mentioned. Before I go to my technique, I thought we'll do an animation video of the Laforce technique, which most of us do by my tech. So that's a diagnostic arthroscopy being done, and that is the anterior ports. The coracoid is, we mark this, visualize, so we prepare the anterior surface of the glenoid. A P minor release, that is a pectoralis minor, which is attached on the medial side of the coracoid. And after that, we make holes in the coracoid. And we prime it, we do a tapping and put washer kind of thing there. Split the subscapularis. And the detached coracoid is pushed through the interval and we fix it. So my steps would be, this is the position, B-chair position. These are portals which I use. And these are the different steps which I explained now. We do have complications. We have malposition complication, we could have infection, we could have graft lysis, which is and nerve injuries, non-unions. So this is one case, 32-year-old male patient, previously operated for Bangalore with failed recurrence multiple times. Bone loss, he was actually operated 2 times, and bone loss at 19%. So this is a diagnostic arthroscopy. You can see the old anchors in place. Here I am clearing the anterior surface. The capsule or labral complex is being elevated, so I have to clear it or completely elevate the. That is, I have to visualize the anterior surface of the glenoid. Then I have to scrape it off the subscapula. The entire thing is being scraped off the subscap, and I push it towards the head. So that's what I'm doing there now. And the old anchors, so they were not metal anchors, they were possibly bio anchors because only the threads had a problem, so I removed all that. And then I do the rotator interval release because I have to cut the coracoid, I have to visualize the coracoid, all that, and for that I need to do a rotator interval release. So I'm doing a rotator interval release when I'm visualizing the coracoid process. That is a CA ligament which is on top of the coracoid process. That's superior surface of the coracoid. So it is released nicely. I'll try to run the video, I know I'm very late. And here, this is what I do. I take a bite in the sin sutures in the capsular labral complex and keep it ready. This I will fix after doing my latarjet. This is the suture there. And then this is the anterior endoscopy. We're doing the anterior endoscopy here. I am visualizing that's a conjoint tendon which I'm coming up. To the right of the conjoint tendon where I'm cutting is a interval between the pectoralis minor and the conjoint tendon. I go up all the way slowly and visualize the coracoid. So I go up to the CC ligament. That is on the surface of the coracoid. You can see that. You can see further down. Okay, on top is the CC ligament, and I put the drill holes, the alpha and the beta. I prepare it, tap it, put the top hat. We call it as the washers are called the top hat, and then I cut it. So there's a drilling which is happening. And that's a tap. Then the cut. We have to be extremely careful with the cut, so we need adequate space. If you don't cut it, if you cut it very short, then the chance of split is there. The coracoid can split, it can fracture, it can. So I've had my set of complications as well. The subscapular release. Next step is that's a subscap muscle in front. So I'm releasing splitting the subscap. So where do I split? I split it at around 6 o'clock position in the glenoid. So correspondingly, I'll be cutting here. After I split it, then I have to visualize the glenoid face and I have to clear it. This is the coracoid. I have to capture the coracoid. I'm capturing the coracoid now with the special cannulas we have, and I have to guide it through the subscap split and then fix it on the surface of the glenoid. Lastly, I finish it with a capsular repair. So I do a remplissage, I do a latarjet, I do a capsular repair, I make the graft extra-articular. This is my technique. This particular patient may not have great results, and the CT also was good. So we do regular CTs at 3 months and 6 months to see how these patients are doing. This is the another case here. This is a complication. I will not go into detail. This is an intraoperative, postoperatively we found that 6 months later, this coracoid broke at the tip alpha, that is an inferior bone it broke. We did a diagnostic, we did a arthroscopic fixation technique, which we got it published. So this is a technique where I took arthroscopically bites in the conjoint tendon and fixed it back to its position. So this is a salvage technique. So arthroscopically we were able to salvage and the patient is doing well. So the follow-up of this salvaged patient. The another thing we had was intraoperatively we had a vertical split. I tightened it too much and split vertically, and we did again a salvage. I put a anchor on the medial side, a lateral side, bridged it, and it healed up very well. And it was a double row technique of fixing it. That means I crisscrossed across the coracoid and fixed it with a push lock on the. You can see that push lock which is coming on the glenoid side. Again, postoperative radiograph of that patient. Why arthroscopic latarjet? Again, this is a patient who had a cartilage defect. We did a BMAT technique of cartilage repair intraoperatively, arthroscopically. We were able to, again, cartilage went to heal well. So that's why my reasons and our results. we have decent results. We have been documenting it. Thank you so much.